So, welcome everybody to the virtual tumor board of Asian Geriatric Oncology Society. This is our the fourth monthly tumor board. So, case number 7 and 8 will be discussed today. I bring you greetings from Darjeeling. I'm here to do a 3-day palliative care workshop in collaboration with Darjeeling Oncology Trust and the Lions Club of Darjeeling. It's been very fruitful so far. Today was the second day, and tomorrow will be the third day. And when we talk about oncology, palliative care, then of course geriatrics plays a very important role. And I'm glad to share with you that a lot of discussion included care of oncology patients in the geriatric age group. So with this short introduction, I will now hand over to the moderators, Dr. Magesh and Dr. Rajiv, to carry on with the proceedings for today's virtual tumor. Over to you guys.
Thank you, sir. We will quickly start with our first case. So today we have got two cases from Gericare Hospitals, Chennai. The first case is a 77-year-old gentleman who has gone through a lot in the last 6 years, and Dr. Vinodh, our colleague and consultant medical oncologist, will be presenting the case, and we'll put some of the interesting questions to the panelists. Over to you, Dr. Vinodh.
Thank you, sir. Yes. Good evening, all. First of all, I would like to thank Professor Purvish sir for this opportunity and AGOS, and my colleague and mentor, Dr. Rejiv sir, for giving me this opportunity. So today we'll be seeing a case of follicular lymphoma, non-Hodgkin's lymphoma, which has progressed through 3 lines of treatment, an elderly gentleman. So he's a 71-year male who was a retired bank manager living with his family and busy with his own business post-retirement. He has an extended health insurance coverage. He's a known case of CAD, underwent a coronary bypass in 2014. Again, it was a regular medical checkup in which he was found to have a CAD, for which he underwent a bypass but was not symptomatic. And later, after 3 years, he developed diabetes and then hypertension. But patient is mobile and he is on his own doing his routine activities. So in 2018, he was evaluated for loss of weight for 1 year and abdominal discomfort. So on evaluation, PET-CT was done. It found to have a supra and infradiaphragmatic lymph node enlargement with moderately enlarged spleen. So we ordered a biopsy from the external iliac lymph node, which came out to be follicular lymphoma, grade 3A. And FISH testing was done, which was negative for BCL2, BCL6, and MYC. But he had this gain of 3q27, and chromosomal analysis was normal. In view of advanced stage and GELF positive, he was symptomatic, and FLIPI high risk, patient was planned for chemotherapy. He received 4 cycles of BR regimen, bendamustine and rituximab, post which the interim PET showed near complete metabolic response in all disease sites. And he was consolidated with 2 more cycles and achieved a complete metabolic response and was started on maintenance rituximab. So post two cycles of rituximab in March 2020, there was a COVID situation. So due to COVID situation, as well as the guideline recommendation at that time, further cycles were deferred after having a discussion with the patient and the family. Here we can see the PET-CT at the end of treatment. There was no disease anywhere. So after a 3 year of DFS, patient was again on follow-up for the past 2 years from 2022. So in 2023, he on routine PET-CT showed a multiple confluent enlarged level 1, 2, 3 axillary lymph node, as well as supraclavicular and mediastinal lymph node. So we did a biopsy from the left axillary lymph node, which came out to be large B-cell lymphoma arising from follicular lymphoma, and the Ki-67 was 70%, suggestive of Richter's transformation. So, Dr. Varun sir, can you please share with us your experience on Richter's transformation in follicular lymphoma, incidences, and how do you prove it?
Hi, Rejiv sir and Dr. Vinodh and all the members of the recur team. Yeah, it's an interesting case. Again, we know in low-grade follicular lymphomas, the incidence of Richter's transformation we see in our practice. So usually when the patient transforms to a high-grade lymphoma, usually patient presents with B symptoms or usually some other symptoms. But yeah, actually in this patient, it was quite it's surprising that patient didn't have any symptoms. Isn't it? Is the patient had any symptoms?
No, he did not have any B symptoms, but he had this large infraclavicular node, which which was clinically palpable. So, but no major B symptoms, yes, and
How
no
was the
aggressive.
LDH? Is there any
LDH,
gem?
LDH was reasonably high. I think it was around 800.
Okay, okay. But it fits with the histology. It can happen, and even actually the incidence is around actually in the tune of 10%, even in the rituximab era. And we usually treat those patients as high-grade lymphomas. And I believe the age of this patient at that time was around 75, right?
Correct, correct. So he was 71 at presentation. Now he's around 74, 75. That's the question that we have for you. So we have a now DLBCL who is already exposed to rituximab and a few doses of maintenance rituximab. What would be your choice if you in the second line?
Yeah, how is the performance status there at that time?
From the excellent one,
Okay.
SPS1, and we will give the geriatric parameters when we do the next line of treatment. But he's
Sure,
excellent.
sure. But still 75 years, good performance status, and also we had a reasonable DFS of around
Yes,
3 years.
yes.
So what I would do in my practice is I will try with the CHOP, I know R CHOP. So what I will do is that I will start with the R mini CHOP in the first cycle, and if the patient tolerates, then I will try to escalate it to at least a modified R CHOP.
So here he had a coronary artery disease,
Okay.
and he had undergone a CABG in 2014. But now the cardiac functions, including an echo, was normal, and he had unlimited, physical activity. So will that be a concern for you to start on CHOP or being taken care
No, sir.
after a CABG?
No, if the cardiac LV systolic function is actually fair enough,
Yeah,
then I will try the adriamycin-based chemotherapy.
sure, sure. So I think that's what we did. So we gave him initially 2 cycles of our COP and then our mini CHOP. Then again, he went into a complete metabolic response, and we gave 2 more cycles of our mini CHOP, and he was in complete metabolic response. And now here comes the dilemma. Now we have achieved a CR2 in a reasonably
Yes.
well preserved lymphoma, but now it is a aggressive DLBCL with CR2. What would be your discussion point at this point?
Again, actually, patient achieved CR after 6 cycles of R-CHOP. Again, in a 75-year-old man, actually, actually discussing about an autologous transplant, I will be a bit skeptical.
Yes.
So we have two options. We can again consolidate because it's a Richter's transformation, high grade.
Yes.
So we can consolidate with the CAR T cell therapy. It's an option.
Yeah,
And
this was in 2023.
yes, sir. Yes, sir. If that option is not there, then I will continue with the rituximab maintenance.
Okay.
Because we have the actually, even though in the lab setting we do not have much data, but extrapolating the primate trial, I think I would prefer to continue with rituximab maintenance.
Sure. I think we were discussing and exactly what your thoughts were. We actually discussed the option of autologous transplant with him. Our transplant team also, though a bit apprehensive, was okay for a discussion, but the patient was very clear that he doesn't want any treatment which can be life-threatening. So we actually kept him under follow. This.
So the patient was on follow-up for the next 2 years, after which again he was asymptomatic doing his own activities. But routine PET-CT showed in August 2025 a lymphomatous recurrence, again in the same site, the axillary, interpectoral, infraclavicular, and this time even in the periportal and portocaval lymph nodes were positive, with splenomegaly having a diffuse uptake. Biopsy from the lymph node again came out to be DLBCL, germinal center subtype stem. So here you can see there is an extensive disease which has come back. The patient was asymptomatic. As Sir has rightly pointed out, other than these symptoms, any rise in LDH, hypercalcemia, as well as lymph nodal enlargement are pointers for relapse or stress transformation for that matter. So here we had again extensive disease. So this time he was around 77 years old at this juncture. So we wanted to do a geriatric assessment. The G8 was more than 14 points, but still considering his age, we also wanted to do the other parameters to know his nutritional status and any depression and mental status. He had a complete point in both nutritional assessment as well as in MOCA, but his Charleston comorbid index was high. There was 7 points because he had 3 comorbids, was on multiple treatment. Here, sir, Varun sir, we would like to know your experience on CARG scoring. Suppose patient has a reduced dose, he has 4 points, what would you do? And if we give a standard dose with an intermediate risk, how would you proceed, sir?
Yeah, it is mainly we do CARG after doing the geriatric assessment because actually we have to know actually how will be the outcome if we use the standard of chemotherapy or modified dose. Usually, if you're planning for actually a combination chemotherapy, then if the risk is more than 50% in an elderly person, what we usually do in our practice is to try to modify the dose. I think in a case of lymphoma relapse, actually we have actually no other choice rather than a combination chemotherapy. Actually, we cannot treat with a single agent chemotherapy here. So actually our options are actually really limited. So we have to treat with the combination therapy. But again, if we apply the standard dose, it will be much toxic for this patient. So I prefer to modify the dose.
Thank you, sir. So we have few questions for our geriatrician. Dr. Magesh, sir, can you explain us about how do you stratify this chronological versus functional age and polypharmacy in this patient?
Yes, Dr. Vinodh. I think, yes, we moved away from the concept of number as an age, and now we more look at the function. And most of us in oncogeriatrics now we are used to this, and we use the various scales, comprehensive geriatric assessment, and activities of daily living to come to a conclusion about the patient's functional age or functional status. And particularly with this patient, even though the comorbidities are more and the number of drugs are more, and there was no red flags highlighted in the CGA, G8. The risk of still, when they are on diabetic and on good diabetic control, I would prophylactically ask them to kind of reduce the number of medications for diabetes or hypertension if it's under good control, because those who have had good control, when they start chemotherapy, especially with minimal side effects, they tend to have hypoglycemia and more of a decline in their function, and we want to prevent an hospital admission. So try to counsel the family, especially to kind of lifelong they've been educated to have good glycemic and good hypertension control, but to kind of reassure them for a temporary period, it doesn't matter if the sugars go high, and so to try and look at the medications and try to scale back temporarily. Somebody like him who has a good glycemic control. So the functional status and in him was very good. So geriatric wise,
the point we wanted to make, sir. For example, in many of our oncology forums, we feel this patient is performance status 1, and G8 screening actually has shown very excellent score. Most of us would go ahead and give treatment at that point of stage, but when we go into the CGA, we could find out, that some of these parameters like comorbids and polypharmacy, even the CARG had intermediate risk for him. So that actually brings us to the point on, irrespective of the performance status and irrespective of the initial scale, screening scale showing good scores, a comprehensive geriatric assessment and a complete geriatrician's review will still help us in polypharmacy management and comorbidities, which can have impact on our oncological outcomes also.
I totally agree with you. I think definitely because many things, especially nutrition and cognition, are two big things in elderly population. And no, we definitely need to have a baseline. And so sometimes it's not possible in an oncological setting. So the geriatrician being a part, or no, some arrangements to get the nutrition and the cognition screened in fit and well patients on G8 is very essential, because they can tend to fluctuate once chemotherapy is started. I think that's the message.
And can I add one thing?
Yes, please.
Yeah, actually, one more important thing, as Dr. Magesh mentioned here, is the cognitive dysfunction. Because he is a 77-year-old man, he already received 2 lines of chemotherapy. So the age-related cognitive decline is there, and also chemotherapy age-related the cognitive decline that is usually seldom discussed in our oncology forums. This all should be actually considered here.
Sure. I think
Before
the
going to the next
important
slide.
point, Varun. But interestingly, you will, at the end of the presentation, you will know that how his cognition and clarity has helped him. So, Vinodh, you can continue.
Right.
So, sir, at the second relapse, the family was not keen on autologous stem cell transplant. So he was on follow-up and he relapsed. Now, what would be the third line option, sir? With this patient already having received BR as well as RBHOP. So what are the options for the third?
Sorry, question is to me?
Yes, sir. Yes, sir.
Okay. Sorry, can you please repeat that question, Dr.
So the
Vinodh?
third line options
Yeah.
after BR and RCHOP failure in a
Okay.
reasonably well preserved gentleman, what will be your thought process, and what will be the regimen you will be thinking about? And
Yeah,
will that regimens depend on CAR-T as one of your endpoint?
Yes, sir. And so now we have actually a relapsed large B-cell lymphoma, extensive disease, but the patient is reasonably well preserved.
Yes.
And I think patient is clear about his actual decision and all, right, sir? Because he can take his decision. And
Yes,
so, yeah, so what I would consider is to achieve a reasonable remission for the patient first.
Yes.
So I would suggest the polatuzumab-based chemotherapy along with the GEMOX rather than ICE or DAP. Because for his age and performance status, I think ICE and DAP will be actually a bit heavy. So my personal preference is to treat with the GEMOX in this patient along with the polatuzumab. And if then I would also consider the CAR T-cell therapy to this patient, and I will consider 2 or 3 cycles of GEMOX as a bridging. And if patient achieves remission, then no, actually even the remission is not required for the CAR T-cell therapy. If the patient achieves a reasonable response, or if I can debulk the disease, then I would consolidate with the CD19-based CAR T-cell therapy.
Excellent one. So I think that was our exact thought process. And actually, we had an initial discussion of CAR-T, and the patient and family was committed to it. So as you rightly told, we wanted a bridging therapy to be given. And we went ahead and gave our Pola GEMOX. We thought about evaluating at 2, but due to some social circumstances, they wanted to go ahead with 1 more cycles and give. So we gave 3 cycles of our Pola GEMOX. And
So the reassessment PET showed complete reduction in the size as well as the activity at all sites. It was a near complete metabolic response. So again,
I would like to know actually any neuropathy issues that
absolutely no. We actually didn't dose reduce much.
Okay.
And we were watching out for early neuropathy. He tolerated excellently well. No admissions. All was only during the for the insurance we had to admit him for the chemotherapy, but otherwise no neutropenia, no tolerance issue. So we went
because the patient
to a near CR after 3 cycles.
Because patient already received vincristine and oxaliplatin.
So that's why I think mini RCHOP would have helped us, because vincristine was likely dose reduced there. But we were mindful that Pola can cause neuropathy, and we were watching for it.
Yes.
So at this junction, we again discussed with the family regarding CAR T cell therapy. The family was really keen to do it. Even we also had a date fixed for him for the first CAR T cell procurement for the plasmapheresis, but patient preference was given a choice because after doing all the appointments being fixed for CAR T, at the final junction, the patient said he's not willing. He doesn't want a CAR T to be done now.
So I think when we had a discussion, multiple rounds, I was very, every geriatric oncology meeting, Purvi sir tells us how patient preference is very important. So here was a situation where the family, including their son, was very keen to go ahead with the CAR T. They were disappointed. The CAR T team with us was disappointed. But then the patient was very clear on what he wants. He said he has achieved a good remission. He doesn't want to go through a costly treatment. He was a bit apprehensive about any ICANS and other side effects of CAR T. So he said he wanted to continue with R-Pola Gemox and see what happens. So he actually, as per patient preference, he opted out of CAR T. And being in geriatric oncology for some time, at least our team was not very disappointed. But that's I think that's what we actually learned, that sometimes the patients are very clear what they want at their age.
Sir, Dr. Varun sir, what about your real world experience on CAR T cell therapy, sir, in elderly specifically?
Yeah, actually, my first patient was an elderly patient, CAR T-cell therapy. So if you see the data, actually the efficacy-wise, it is almost equivalent. If you take the long-term data of SUMA-1 trial, actually the efficacy is almost similar in elderly patient and younger patients. Even actually now the 10-year, the update of SUMA-1 is also now is out. So if the efficacy-wise, we do not have much confusion. But if you take this safety, if you take the subgroup analysis of both the Axicel and the Tisacel trial, the increased chance of the cognitive dysfunction is there, particularly if the age is more than 65 years. But in the trial it was not statistically significant. But actually we have to strongly consider that also. That is why a baseline cognitive dysfunction and a detailed CGA is exactly needed before you are considering an elderly patient for CAR T. And another important factor in elderly patient is that the chance of infections is more, because the patient will be, we know after CAR T, the patient will be immunocompromised for months, and the patient already having multiple comorbidities like the diabetes, COPD and all. So the chance of infections and the non-relapse mortality is actually a bit higher in elderly population. So this all should actually, we should take care when we are the offering CAR T cell for an elderly patient. But definitely, if you take the efficacy wise, it is almost equal. There's no inferior efficacy in elderly patient. It is equivalent with the younger population.
Yes, sir. So as you rightly pointed out, sir, the biology says once the age increases, the proliferation ability and cytotoxicity of the T cells decrease, and memory T cells are affected, and senescence associated markers inhibit the CAR T cell therapy. But the real world evidence from US, from 16 centers, where it is purely about the octogenarians who are more than 80 years, 88 patients were included. And as you have rightly pointed out, the efficacy was really good. Almost 71% received complete response here, and 61 were alive even after 1 year. And grade 3, grade 4 adverse event, as we can see, it is very less. It was only 7% with CRS, but ICANS rate was a bit higher, 31%. So again, it's going to be an individualized decision. And as you rightly pointed out, the geriatric assessment, the comorbidities, or family preference or patient's preference, all this makes sense before taking a decision of CAR T cell therapy in older patients.
Yeah, if you see the CRS rate, it is almost comparable to all other age group. But if you
Yes,
take the ICANS or the
yes.
cognitive dysfunction, it is different. So particularly in patients more than 65 years.
Yes. Very important practical points told. So this brings us to the end of our first patient discussion. We have some chats. We will look into the chat boxes, and we will also go to the next case, which will be moderated by Dr. Magesh. And this comes to the end of other end of the spectrum, where in the first patient we could do almost all the standard of care treatment. The other one was a patient where we need to take him to his end of life with all the available resources that we had, and we'll see how in a real world situation that happens in a geriatric oncology unit. Over to you,
Sir,
Dr.
Rejiv sir, one more thing. In the last patient, what you offered at the end to the patient?
So we are going to complete 4 to 6 cycles of our Pola Jamox. If neuropathy, we will take out Pola, and then he wants follow. So he's on the 5th cycle of Pola Jamox.
All right. Thank you.
Thank you. Thank you, Dr. Rajiv. I think we move on to our next case. This highlights the importance of not only the assessments which we do in elderly patients, it's more about the services we can offer as a unit. And as Dr. Bharathi, our palliative care physician, takes us through the case, we want to highlight the amount of geriatric services involved in an oncology patient, especially in an elderly oncology patient. Over to you, Dr. Bharathi.
Very good evening to all. So we all know that cancer patients suffer a lot of physical distress, but there are other components to distress like psychological distress, social issues, and spiritual problems, which are often not assessed and treated in such patients. So today we are going to discuss about an elderly gentleman who had all these issues and he was suffering from total pain. So our patient is a 69-year-old gentleman, and he was suffering from multiple comorbidities which were well controlled, and he was a retired government employee. The primary caregiver was his wife, and the decision maker was his son. So short treatment history: in 2010 he was treated for carcinoma tongue. After that he developed recurrence in 2022 when he had radical re-radiation and chemotherapy. So his current presentation is a large proliferative lesion. You can see in the image that I have shown that was protruding from the oral cavity. So he also had an ulceration in the submental region. So he developed stridor, and he had to undergo an emergency tracheostomy procedure for that. Following that, he was discharged and he was at home. So they had requested for an home visit consultation since he had developed some new complaints. So an assessment, it was found that he was having a discharging malignant ulcer and pain. So patient was transferred to the hospital for further assessment and management. So we can see that in an elderly cancer patient, so the need for home care and the importance is high. So I request Dr. Anupama. Ma'am, can you say what are the key challenges in managing elderly cancer patient in a home, and how to bring about the smooth transition, like sometimes from the hospital to home or from home to hospital? Over to you, ma'am.
Just a brief
Yes.
introduction, Dr. Anupama. I think Dr. Anupama is a senior geriatrician who's had home visits experience for over 15 years now, and we are privileged to have her with us. Over to you, Dr. Anupama.
Thank you, sir. For the patient under discussion, during consultation at home, he was found to have fever, bleeding from the oral lesion, discharge from the malignant ulcer, and a lot of purulent discharge from the tracheostomy wound and desaturation. So now this was beyond the scope of management at home. So he was advised admission to hospital for further management. Now, as a community geriatrician who deals only with caring for elderly patients at home, the single most standout challenge would be the scenario at home, where the patient's attenders take the upper hand as against the treating home care physician. They assume a more dominating role at home than in the hospital. More often, I need to listen to them before preparing any care plan. Now, after careful assessment of the patient's clinical condition, including cognition, previous level of function, my care plan would constitute, first and foremost, empathetic listening to the goals and wishes of the patient, after ensuring that he fully understood the nature of the cancer and its prognosis. Then I make sure that there is a space for patient care if already it is not adequate, with proper bedding, inclination for propping up the patient if needed. Then I would give advice for good sanitation and hygiene. Also, I would take care of his hydration and nutrition. Make sure his bowel and bladder is adequately cared for. Also, to manage pain effectively using the 3-step analgesic ladder. Also, I would take care to de-prescribe and manage polypharmacy in order to avoid any dangerous drug reaction. Also, I need to monitor for and treat any infections arising due to the immunocompromised state of the frail patient with reduced functional reserve. So infections like pneumonia, urosepsis, I try to handle at home. Along with this, the other comorbid conditions like heart failure, diabetes, or hypertension, these could spiral out of control due to the cancer chemotherapy. So those also are managed at home. Caring for wounds, pressure ulcers, assessing feeding and inserting Ryle's tube if needed, initiating intravenous therapy as the case warrants. Then if episodes of delirium, which usually occur, then they are watched for and treated. Any electrolyte disturbances are rectified. Also try to assess for any pre-existing cognitive impairment. Identify depression, behavioral disturbances, and treat them as well. Last but not the least, allocate time for counseling and educating the caregiver and suggest strategies to sort of empower them and identify caregiver burnout. Regarding the next question, so usually patients discharged from our hospital while transitioning to home care, usually they are given a well-formulated care plan, usually with specific instructions for the home care physician. Now, ideally, such a care plan would include diet, hydration advice, need for any special medical equipment like BiPAP or the oxygen concentrator, detailed information about the past medical history and hospital stay, the medication list, which include, apart from the general medicines, need for opioids, need for any psychiatric medication, history of any allergies, his functional status regarding the activities of daily living, sensory aids like dentures, glasses, hearing aids, mobility status with mention of assisted equipment, if any, also his psychosocial and behavioral state, specific treatment for wounds, then his bladder and bowel incontinence, note to be made about his last bowel movement while discharged from hospital and receiving at home, care for the nutritional status, any feeding concerns, swallowing difficulties, then follow-up care details regarding his general like geriatric the oncology, speech therapy if any, physiotherapy if needed, and all with the collaboration of the lab results. So if plans are made ahead of discharge, then necessary home modifications can be done to create a safe and efficient care space at home.
Thank you, Dr. Anupama. I think the transitional care plan is what we call in our hospital for all patients who get discharged. And like Dr. Anupama has highlighted, specific points to be done is highlighted, and our doctors sometimes know, if they know the particular home visit doctor is going to be involved, they do have a call and explain to them what further care is needed. Thank you. Over to you, doctor.
So moving on to our patient. So we had a family counseling. The patient's son was living abroad and he comes to India only for short visits. So the oncology team has explained to him regarding the disease burden and the prognosis and the availability of only minimal treatment option. But he was very keen on having some form of oncological treatment for his father. So we had also given option of comfort only care, and it was all explained and documented. So because of his preference, he had chosen palliative oncological treatments. And the main challenges which we had faced when it comes to the patient communication was he was not able to speak, though he was able to write. So addressing his autonomy was a challenging one because of these communication issues. So further, the patient underwent a palliative debulking for the growth of the tumor that was protruding from the oral cavity. So I would like Dr. Kathiresan sir to explain regarding the role of palliative surgery in advanced head and neck malignancies.
Hi. Good evening, everyone. So, in this thing, role of palliative surgery, when we look at in advanced head and neck malignancies, like this patient has already underwent an tracheostomy, which is again an palliative surgery where the intent is to improve his quality of life and to relieve his symptoms. That is what will be the intent of our surgery, especially in this kind of a setting. And this patient has had one surgery for breathing difficulty or stridor, where he had a tracheostomy. And this actually, this patient had a lesion which was protruding through the oral cavity, and he was not able to close his mouth. So in that setting, we just tried to, under local anesthesia, because he was not fit for any general anesthesia or anything, we try to remove that tumor under local anesthesia so that he will be able to close his mouth, and that will give him more comfort. And other than these, when we have to look at doing any procedures for his nutritional aspect, especially inserting a Ryle's tube or doing a feeding gastrostomy or a jejunostomy, or when there is any bleeding, especially in head and neck cancers, which is much more common, where we'll be looking at either embolization or doing a carotid artery ligation, depending on the area where the bleeding is from, and also whether we'll be able to do in such a case. Especially in this patient, fortunately, we didn't have any such event. But because he had twice irradiation and the neck was woody on both sides, we wouldn't have been able to do a carotid artery ligation. Probably, if at all there is a bleeding, we would have thought of embolizing him. And other than that, if there is any fractures or the fixation of the fracture, or to mainly for pain relief, and also to make him ambulant depending on his expectancy or survival expectancy. And that is what we'll be looking at as part of palliative surgery.
Going on to a patient, the biopsy came has a squamous cell carcinoma with PDL1 40%.
So, Dr. Jovita, these are patients we see regularly in our clinic, heavily pre-treated, performance status is poor, nutrition is poor. He may not be fit for any form of IV chemotherapy, but the patient and family is very keen to do something meaningful, not to improve his survival or long-term remission, but any meaningful treatment options which will improve his quality of life. So, how will you face this difficult situation? We went and asked for a PDL1 that was quite high, 40% positive. So some of the Indian data is also available with us. So how will you be discussing the systemic treatment options for this patient, Dr. Jovita?
Sir, actually, we can attempt to do immunotherapy if they are also willing to do, and if the finances allow them to do it. So it can be a single agent, or I would say maybe a very low dose chemotherapy with the a low dose nivolumab. Even that is acceptable. The next other choice will be oral metronomic chemotherapy. So that also was going on in my mind, if that may be used. But in this case, I believe the way the sound of it, it looks like, he's only good for a supportive care.
Yes, absolutely. So I think these were the discussion points that we too had, because we felt after all the assessment, he may not benefit from any form of aggressive chemotherapy. So we did discuss about oral metronomic therapy and immunotherapy, and we went ahead and gave oral metronomic therapy and immunotherapy.
So he received 2 cycles of immunotherapy, and I think we have discussed.
Yes, I think we have discussed the role of immunotherapy in geriatrics. I think this brings a question as part of being a part of the team, when to integrate a palliative care physician in the treatment plan, especially when there is a lot of active treatment going on. when we were training, it was always when the treatment options end, that's when we think of referring to palliative care team. But is it still the same, or has the thinking changed now, Dr. Bharat?
So, the current recommendation is early integration of palliative care. So before going to that, I'll just give a brief definition alone. I know most of you must be knowing, but just to refresh. So palliative care is basically given to improve quality of life of not just the patient, but also the family, and giving them relief from multidimensional problems like psychological, physical, and spiritual aspects. So, and the modern definition aims at patients who are who can be cured. I mean, we are not very sure. Like it is they say that a cure may be unlikely. Still, you can integrate palliative care. So you can see that our patient had multidimensional problems. So that is the main reason why palliative care is extremely important for him. So the early integration of palliative care means palliative care should be integrated at the time of diagnosis itself, and it should go along with the curative treatments and towards the till the patient dies, and then after the patient dies, it should continue with the bereavement support. So there is another model also in which they have incorporated the patients who are potentially curative. That way, you can see that this is a bow tie model because it looks like a bow. So there are two intersected triangles. So the blue one is a treatment option and the pink is the palliative care. So you can see that palliative care has been integrated from the beginning. So and it goes on till the end. When the patient is getting cured, he goes in for rehabilitation and survivorship. Suppose the patient is not getting cured, then he'll go for end of life and then end of life care and bereavement care for the family. So the key message is early integration of palliative care.
I think what we have seen in practice also is when we have a palliative care physician is with us, the earlier the referral, it is better because that helps the patient and family to have a rapport with the palliative care physician, and early integration helps in more difficult conversation later, which includes the end of life care and comfort care. Because if you do a late referral, usually that communication may not be very easy, and it will to the burden on the palliative care physician may be more.
Yes, I think I mean, there must be some criteria. We can't refer everybody. Do you have any referral criteria, Dr. Bharat?
Yes, sir. So there are so these are the basic referral criteria. So the referral criteria are broadly divided into needs-based criteria and time-based criteria. So needs-based criteria are when the patient is having severe physical symptom, emotional distress, psychological problems, spiritual distress, or when the patient is requesting, or when the patient is having delirium or brain metastasis or spinal cord compression. Time-based is within 3 months of diagnosis of an advanced malignancy when the median survival is less than 1 year, or diagnosis of an advanced cancer with a progressive disease despite second line of chemotherapy. So these covers basically all the criteria for referring a patient to a palliative physician. Apart from this, NCCN has also come up with a lot of referral criteria. They are also in par with what the previous slide was telling. So additional thing is they have just added a few important aspects like need for when the patient has got need for intensive care level involvement with multi-organ failure, or when a patient is needing prolonged mechanical ventilation. This could be a patient who is actually on treatment. Maybe he might be on for a curative treatment when he develops issues like that. In that situation also, integration might be helpful for mainly counseling and talking with the family. And also when there is a lot of family conflicts, in that situation also they say it is good to integrate palliative care. So we can see that in every aspect we are speaking about all these psychological issues. So the most common issues at the end of life are like anxiety, depression, suicidal thoughts, death wishes, and fear of suffering. So I would like Miss Swetha, she's our psycho-oncologist. So can you tell about role of psycho-oncologist in care of cancer patients?
Thank you, Dr. Bharathi. Amongst head and neck cancer patients, the amount of distress is actually comparatively higher when you compare it with other cancers. So we usually use the NCCN distress thermometer, which is a single item question, wherein we mark the distress from 0 to 10, and this can be done easily during every visit of their to the OP. So based on their distress, we can identify areas where they have problems. And amongst head and neck cancer patients, it's very common for them to have body image issues, especially if they have Ryle's tube as well. And apart from the physical complaints such as swallowing difficulties, difficulty in communication, so as we all know, these are quite vital parts which actually affect our day-to-day functioning. So patients with head and neck cancer might have low self-esteem. They might withdraw themselves from society. They might reduce the number of people they want to talk to, and they could actually quite limit it just to their physicians or even very close family members. So it's important to understand them from the very beginning and help them voice out, even though they can't do it physically. We should not make them feel unheard. So as much as possible, it's important to integrate their viewpoints into the treatment. And in many cases, the family is not in the same page as the patient. So it's important to counsel the family as well, and kind of integrate both family and patient into the care plan as well. So it's important to keep their quality of life in mind and psychoeducate both family and patient as well.
Thank you.
So we'll go back to our patient. So our patient developed some moderate tumor bleed. So we held a family meeting where we clearly explained regarding the current condition of the patient, and that any intervention that we offer for stopping the bleeding may or may not sometimes give relief from the bleeding. So, but the family still wanted to try intervention to stop bleeding. So he underwent a bilateral lingual and left facial artery embolization. Thankfully, after that, he did not have any bleeding. So that helped him a lot. So after this, we had stopped further oncological treatment, and patient was shifted only to comfort care. In an elderly patient with advanced cancer, how to decide on when to stop the disease-directed treatment? Sir, Dr. Varun, are you there, sir?
Oh, hi.
Doctor, yeah, Varun, you're there?
Yes.
So I think this is one of the most difficult decisions from a
Yes,
medical
yes,
oncologist point of view. All the years we have been taking care of them, and suddenly one day you tell we are stopping everything, and the family most of the time is not willing to accept that. Patient also wants some hope. So how do you deal with this particular decision in an elderly patient, especially with all the family around?
Yes, sir. I know, as you said, it all depends upon the multiple factors, like all the previous the treatment that patient received, and the toxicity, the drug-related toxicity, and other comorbidities, expected
So
life
from the
expectancy.
oncologist point of view, we are very clear that it may not help him further.
Yes, and
How will on the ground, how will we be dealing it with the patient and the family?
so actually, first of all, we have to see what are the available options left for the patient, and how efficacious they are, and will they going to improve the quality of life rather than improving the survival. If no, then actually, so I would not they push the patient for further treatment. So I would refer the patient for the hospice or best supportive care. In majority of the situation, actually, our Indian patient usually it's difficult for them to take a decision. So as an onco physician, may I also help them to come to a decision. So
Again, an early referral to a palliative care
yes,
physician
yes,
helps us smoothen this transition rather
definitely.
than when we tell
because
them nothing
because
much is
at the
there.
end,
Yes.
actually, after spending the lakhs and lakhs of money,
Yes,
and then actually suddenly a new person comes into the
that's true.
picture, it will be uncomfortable for the patient. So it is always better to integrate the palliative care at the onset itself.
So moving on, so our patient was transferred to comfort care. So the end of life care can be provided at home or in the hospital only for intermittent hospitalization, like the patient is requiring some titration of medication, or if patient is requiring any palliative procedures. So the other place is the assisted living care or in hospice care. These are basically depends on the need of the patient. So So I would like Dr. Vasanth to just enlighten us regarding the impact of assisted living on our geriatric population. So, and which individuals in this elderly age group are most likely to need assisted living? And is it actually accepted?
Good evening, all. So I am a geriatrician exclusively involved in the facility-based care and home care, like Dr. Anupama. So I think 10 years back, this assisted living terminology was non-existent in India. So everyone knows about home care, old age home, and probably hospice care. But this assisted living, it is nothing but a structured, safe environment for older adults who need constant support. But they do not require a hospital level or an ICU level support. Now, when it comes to impact on geriatric population per se, first of all, the improved safety. When it comes to assisted living, we focus on reducing the medication error, focusing on the hydration of the patient, reducing the chances of malnutrition, and the incidence of falls as well. So these become our quality indicators. And when it comes to symptom control, again, the regular monitoring of the pain, constipation, fatigue, delirium, these geriatric syndromes, those are better monitored because of the structured environment. And most importantly, the enhanced quality of life. So this will, we have structured our environment there where there will be more socialization, meaningful engagement. Even a bedridden patient is brought into the wheelchair. They are made to participate in social activities. So, and this also reduces the caregiver burden. Okay. And again, this assisted living serves as a care continuing between a home and a hospital. So this is something which we need to plug in, because see, most of the palliative physicians in India are trained in oncology hospitals. We as a geriatricians are not trained in oncology. To be very frank, during our MDTs, we are not trained in oncology. So when these people come together, so it is new learning for each of us. So when we started assisted living, palliative care for us meant every patient, not only cancer patients, all other patients, and majority were non-cancer patients. In fact, in our assisted living at Gericare, I would say less than 10% of our patients needing palliative care was cancer patients. So it was non-cancer patients was the majority. And one more important impact we made was the reducing hospitalizations, the early detection of complications like dyselectrolemia or infections, delirium, or even chemo-related dehydration. So those are something which we would identify at the center and reduce the chances of readmission. When it comes to which individuals in the elderly age group are most likely to need assisted living, again, it is the basics of geriatrics. The CGA you do will give the clue about the functional dependency, right? So the ADL dependent, the bathing, dressing, toileting, feeding, need individuals, those who have poor mobility, those who are room bound, and again, oncology patients who become weak post chemo and radiotherapy. So most often we find patients who travel, who make an effort for chemo or radio, and and unfortunately they have to wait for their turn when it comes to RT and all that. And when they come back after a 2-hour travel, they are dehydrated. They go into for hypotension episodes. So that is when these kind of facility-based care, helps us. And second thing is the cognitive decline. Most often elderly patients, 70 and 80 plus, when they undergo this chemotherapy, when they have to manage so many medications and routine, cognitive decline in the background, it speeds up. So that is something which can be identified, and a potential delirium can be avoided. And third most important thing is the complexity, the comorbidities. It is not only cancer. The patients have the diabetes, COPD, CKD, heart failure. Now, these are something which needs to be monitored as well. Most often we find oncology patients, doesn't not caring about those comorbidities when they get back home, focusing only on oncological treatment, and they get into a worsening of their CKD or the heart failure. So those are some things which can be addressed at the facility. And when you see socially who will be the right candidates, of course, patients living alone or with a frail spouse, and again, NRI families, because most often it is NRI children who wants their parents to be at the best care for facilitating these, moving into oncology unit, coming back and all that. And again, burnt out family caregivers, because managing a geriatric patient with an oncological problem is quite a difficult thing, because it is a longer period, and invariably the decline is expected in terms of function. So the family caregivers all do get burnt out because of that. When it comes to acceptance of assisted living, it is still growing. It is growing steadily, especially in the metros. Why? Because what we feel is in the metros, there is usually dual income or multiple income family households. It is the siblings who fund the parents' treatment and all that. And second, the NRI families are more in the cities. So again, that is helping, for their rapid acceptance and their exposure to, care in the UK and US, where these terminologies, skilled nursing facilities, assisted livings are already accepted. So, and again, what we see is families with already a complex geriatric need. They would have cared for their mother-in-law or father-in-law, and when it occurs to their spouse, they know what is the journey ahead. So when something like this is offered, they readily take it. And I would say the stigma is definitely decreasing because most often these old age homes and hospice centers were run not for profit. So we can expect, the care, it was burdened financially. The facilities were burdened financially, and the trained manpower will be on the lesser side. But now, when it comes to when it is a paid facility, we are expected to give the best possible care, best possible nutrition, nursing. So this stigma is definitely reducing. And again, when it comes to challenges associated with the assisted living, see, it is enormous. Okay, first of all, the clinical challenges itself, because managing the polypharmacy, delirium, behavioral symptoms, this is for a geriatric patient. When it comes to oncology, again, the everything double and triple fold. And then need for trained geriatric staff. So that is something which is quite challenging because when you scale something like an assisted living, when you want to have more centers like this, training them with good clinical exposure is very, very vital. And we found that we cannot restrict them with an SOP. Especially when you handle geriatric patients. So because each family comes with their own set of treatment care plan, and as Dr. Anupama said, we need to bind their words into the care plan always. And again, of course, the family guilt, that is something which is enormous when in the end of life care, because patients, the sons or daughter want to be frank, they want to time the death. Please hold on till I come, or let me know so that I can book my flight tickets. Now, these are questions which are directly asked. It might sound insensitive, but I think that is the reality. And most often we go out and ask them, are you planning a travel? Are you asking these for this? So when we have this open conversation, I think they feel little lighter, and the guilt part is taken care also. And again, the most important challenge is the financial challenge, because most of the patients pay out of pocket, and it is really long term. And when it comes, they have to repeatedly pay, and when the care level goes up, the cost goes up. So that is when the patients feel the need for the insurance, the long-term insurance, which is non-existent here. So challenges are there, but still with evolving needs, various models coming up, this is definitely a boon for geriatric oncology patients. Especially this patient made use of our facility till his end of life.
Thank you, Dr. Vasanth.
So moving on to our patient was transferred to assisted living facility to receive end of life care in accordance with the patient and his family's preference. So as Dr. Vasanth has told, this family had a very elderly caregiver. So they wanted to have an end of life in a facility where that could happen in a very dignified manner. So we had also formulated the care plan for him, for which we have to do a goals of care discussion. Goals of care discussion is basically to find out what the patient wants and to match the care aligned with the wishes of the patient. So the general things that have discussed are usually regarding cardiopulmonary resuscitation, any medical intervention, yes or no, or if needed, life sustaining measure, and need for any NG or a PEG insertion. So, and also to discuss regarding the preferred place of care, whether they want it at home or at a facility, and wishes regarding the final rites also needs to be discussed. Usually, we have found a lot of patients who actually tell us where to do the last cremation and what kind of prayers they wanted, and many people even select the wood for their coffin box. So much is there, and all these make a lot of impact for them because they feel that is the last resting place for them. So right to refuse treatment. So any patient who is capable of making a decision can refuse treatment, and we should not force them to have any treatment. So this is in accordance with the judgment from the Supreme Court. So our patient passed with dignity, and his family also was with him in the assisted living facility.
Thank you, Dr. Bharathi. I think we just finished on time, and hand over the session back to the organizers.
We have any questions in the chat box? We can see. Yeah, I think we are off time. Dr. Prem, you want to summarize? And
Yeah, I think it was two varied cases, and it was very important that palliative care was sort of talked about. And great insights, Vasanth, on I literally sort of could see your experience coming out there. So overall, I think a very varied session. I think we should close now. Looking forward to meet some of you in Pune very soon. Bye bye. Have a good night.
thank you. Thank you.